morning. So let me present you my PhD topic, which is New Frontiers in Disease Activity Monitoring and Therapy in the Field of Dermatology and Rheumatology. I'm Fanni Meznerics, and I'm a PhD student at the Department of Dermatology, Venerology, and Dermatooncology of Semmelweis University. My vision is that patients with chronic dermatological and rheumatological disorders could have a better quality of life, and that I would like to achieve that by urging the implementation of novel disease-modifying and monitoring methods in clinical practice. Here you can see my specific goals. My first project is related to the investigation of the utility of the multi-biomarker disease activity score for the monitoring of rheumatoid arthritis, while my second and third topics are related to the investigation of the efficacy of platelet-rich plasma treatment in chronic wound management and also in the treatment of alopecia areata. So about my first project. Rheumatoid arthritis is a chronic autoinflammatory disease with a prevalence of 0.5%. The intensive monitoring of the disease activity is crucial for the treat-to-target therapeutic approach. However, there are many subjective and non-specific monitoring parameters at hand, like DAS28-CRP and ESR, which contain the clinical assessment results of the clinicians and also the patients. So multi-biomarker disease activity score is an algorithm based on the serum level of 12 biomarkers, so it is an objective tool for disease activity monitoring. So our aim was to determine the correlation of MBDA score with conventional disease activity measures like DAS28-CRP and ESR, and also the predictive and discriminative value of MBDA score for therapy response, remission, relapse, and radiographic progression. We had several clinical questions with several PICOs. I would like to present only one of them, which is that how does the MBDA score correlate with conventional disease activity measures? So you can see here the information about our search and selection process and the results regarding the correlations of MBDA score with DAS28-CRP and DAS28-ESR, the most widely used conventional disease activity measures for the monitoring of rheumatoid arthritis. We can see here that there were low positive and moderate positive correlations with MBDA score, between MBDA score and DAS28-CRP and ESR. And based on this and our additional results, we concluded that MBDA score could be a valuable asset and tool for objective disease activity monitoring. And as it is to complement, not to replace conventional disease activity measures, its deviations from the conventional disease activity measures can even be advantageous. Here's the status of my first project. It was accepted last December to Rheumatology, Oxford. And my second project is the investigation of the efficacy of platelet-rich plasma treatment in chronic wound management. Chronic wounds are common medical conditions and have a high impact on the aging population. The cost of wound management is estimated to account for 5.5% of all healthcare expenditures, and chronic wounds can also lead to a serious deterioration in patients' quality of life. The standard treatment is smart dressing and compression, but the special bandages which are used for dressing are not the only thing which are making the ulcer management so expensive, but also the human resources, because the recovery time of ulcers is really long. So if there's an additional treatment modality which could shorten this recovery time, it could not only improve patients' quality of life, but could also be beneficial for the healthcare system. So platelet-rich plasma could be this add-on treatment modality. It is a relatively new treatment modality in the field of dermatology, and it contains concentrated growth factors and cytokines, which can promote tissue repair and regeneration. So our aim was to evaluate the effects of PRP on wound healing in chronic wounds. Here you can see our clinical question and PICO. We included studies investigating the efficacy of PRP and comparing it to conventional ulcer therapy alone. And our primary outcome was the change of wound size, while secondary outcomes included healing time, infection pain, amputation, and adverse event rates. And our hypothesis was that additional treatment with PRP is superior to conventional ulcer therapy alone. Here's the information about the search and selection process and our results regarding the complete closure of wounds. So we can see here that the odds for complete closures were more than 5 times higher in the PRP group than in the conventional therapy group. And this is also a clinically relevant and a statistically significant difference between the two groups. So we can say that PRP is a new, safe, well-tolerable add-on treatment modality in chronic wound management, which can not only improve patients' quality of life by shortening their recovery time, but can also be beneficial for the healthcare system. And here's the status of my second project. It was accepted last December. And coming to my third topic, the investigation of the efficacy of PRP treatment in alopecia areata. Alopecia areata is an autoimmune condition where we can see inflammation-induced, usually patchy hair loss. It can affect the scalp, the beard, or even the whole body, leading to a serious deterioration in patients' quality of life. The lifetime incidence risk of alopecia areata is estimated at 2.1%. And regarding the treatment options, triamcinolone acetonide is the first line of treatment in localized alopecia areata. And as it is an intralesionally administered corticosteroid, there can be some concerns with this treatment modality. One of them is adverse effects like atrophy or telangiectasia. The other one is steroid phobia, which is a more and more commonly seen phenomenon in the field of dermatology, when patients fear the steroid treatment and therefore don't want to get the steroid treatment. So when any of these problems occur, PRP can be a great alternative. As I've already mentioned, it contains concentrated growth factors and cytokines, which could not only promote tissue repair and regeneration, but also hair regrowth. So our aim was to evaluate the effects of PRP on hair regrowth in alopecia areata. And here you can see our clinical question. And we compared PRP to triamcinolone acetonide, the gold standard treatment for alopecia areata. And our main outcome was the hair regrowth, estimated with the help of the SALT score, which is Severity of Alopecia Tool score. SALT score shows us the percentage of hair loss affecting the scalp. It is a scale from 0 to 100. So the greater the decrease in the SALT score is, the better the improvement of the patient. And our hypothesis was that PRP is as good as triamcinolone acetonide in the treatment of alopecia areata. Here's our search and selection process. We could include at the end 6 studies, but only 4 of these were eligible for quantitative analysis as well. And here are our results regarding the efficacy of PRP and TRL treatment. We can see that the pooled mean difference was 2.04, which is not a clinically relevant difference. As I've mentioned, SALT score ranges from 0 to 100, and also it is not a statistically significant difference. So our conclusion is that we could not detect a statistically and clinically relevant difference between the 2 groups. However, these results should be considered with caution, as there are very few studies included, and also the confidence interval is quite wide due to the statistical methods used for this analysis. So PRP could be a great steroid-free modality in the treatment of alopecia areata. It can be used an unlimited number of treatment sessions without the increasing risk of adverse effects, and it can also be an alternative in case of steroid phobia. However, further high-quality RCTs are needed to better assess the efficacy and strengthen the quality of evidence. And here's the status of my third manuscript. It was accepted last July. And here's the summary of my 3 projects, which is the same as my first total publications related to my thesis. And I was lucky enough that I was involved in several other research projects during the last 2 years. So here are my other publications. And I'd like to thank you for your attention, and I'm happy to answer your questions if you have any.
Thank you for the nice presentation. I just have a kind of stupid question. What is the better choice? Trying to achieve a regrowth of hair, or just simply shaving it off?
Thank you for your question. Well, it totally depends on the patient's needs. And even though it's not like a painful disease, just simply the loss of hair or the absence of hair can seriously deteriorate patients' quality of life, especially for women, and also sometimes for children. So I wouldn't say that it's always the best choice to just shave it off, but of course, for some people, definitely.
Technically, it was the question of myself, whether it has a problem in the future if I just shave it off when I start going to bald.
Well, that's absolutely your choice.
If it does not mean for me too much, then it's not a problem, if I understand.
I don't think so.
Thank you so much.
I have a question regarding the application of platelet-rich plasma. It can be considered as a biotherapeutic. How was it applied? And what is the future of such therapies in alopecia areata?
Thank you for your question. So in case of alopecia areata, it was injected. Both the triamcinolone acetonide and the PRP was injected to the scalp. However, PRP can also be applied topically. In case of chronic wounds, for example, it's much easier to apply topically. But also in case of alopecia areata in the future, it could be applied topically, for example, after fractured carbon dioxide laser treatments or after microneedling. So if we provide the circumstances for it to actually go into the skin, it can also be effective. But also, even the injected administration is there are lack of information. So we need further studies with injected application and also with other application methods.
So there is an intention to change to the invasive injection to the microneedle patches.
Yeah, absolutely.
So is there any evidence for the 3D bioprinting of platelet-rich plasma?
Excuse me, for what? Sorry, I couldn't hear.
Is there any evidence of the 3D bioprinting of platelet-rich plasma to patches with the microneedles?
Yes, thank you for your question. I've read some articles. We didn't include these as we try to make the populations homogeneous, but there are a few studies assessing their efficacy. Yes.
Thank you.
One short question, so very interesting, but do we have any suspicion about the active ingredient of the applied drug in this case, which is the plasma? So probably within the platelet, but do we know exactly what it is, the active agent? Because if so, it could be produced as a recombinant or something like that.
Yes. Thank you for your question. We don't have exact evidence on which component of the platelet-rich plasma is effective or what's its way of effect, but there are several studies investigating this question, and the conclusions are mainly that the several growth factors which are in the substance are the reasons for its effect. So platelet-derived growth factor, VEGF, insulin-like growth factor, and so on, and also interleukins. So that's because also there could be an immunomodulatory effect as well, which in alopecia areata, for example, is a key component of the disease.
So just tightly linked to the previous question, does the therapeutic success depend on the variability of components of the PRP in these cases?
Yes.
Do you have any remark?
Yes, thank you for your question. Absolutely is the short answer. We tried to make subgroups based on how the PRP was prepared. Unfortunately, it wasn't feasible because most studies didn't include detailed method of preparation, and for alopecia areata there was really few studies, just without subgroups as well. So, but we included this in our limitation sections, and also if you just look at the studies separately, just one study when they had the exact details of preparation, we can see differences like that, but not like we couldn't analyze this statistically.
Thank you. So my question is that in your first topic, what was your outcome?
Well, my outcome was the correlation of the correlation coefficient, basically.
Yes, and what kind of correlation coefficient you can use?
We can use Pearson or Spearman's correlations coefficient. In these cases, I mean, the studies used both. We could only conduct meta-analysis or quantitative analysis for the studies which use Spearman's correlations because we didn't have enough data on Pearson's correlations. But we also visualized them in not forest plots, but kind of like forest plots, and this can be found in the supplementary material of the paper. But what I presented was Spearman's correlations.
Thank you very much.